So I'm Barry Holcomb. I have been in the Four Corners area since 2015. I live in Bayfield, so I commute back and forth. I was at Mercy for about 9 years or so, and Dr. Webb and I started working on a plan for me to come over and open up a service line for pulmonary medicine this summer. And we finalized the deal, and I came over, started seeing patients the first week of December, and I'm super happy to be here. So background. So I grew up in Mississippi. I'm a Southern boy by nature. My dad moved us to Colorado, 1990. My parents live in Grand Junction. And I finished up my undergraduate at Ole Miss in Mississippi, and then came out and did medical school and residency at the University of Colorado in Denver. And then I did my pulmonary critical care training at Vanderbilt, which is where I did my fellowship. I'm board certified in internal medicine, pulmonary medicine, and critical care medicine. So I'm triple board. Next. Here's a pretty picture. I believe that's Vanderbilt. Already did that. So I'm licensed in Colorado, Arizona, California, and New Mexico. So I see New Mexico patients, lots of Colorado patients. So first off, what is pulmonary critical care medicine for those of you who don't know? Pulmonology is the study and the care of lung diseases. And I'll get into what those include. There's a lot of them, but they're very prevalent. And then critical care, of course, some people probably got familiarized with what critical care was during COVID. Critical care is intensive care unit medicine, managing life support machines, critical illnesses like multi-organ system failure, sepsis, heart failure, ARDS, which is what the COVID patients were getting, where their lungs fill up with fluid and they have to go on a ventilator. I've been doing pretty much exclusively pulmonary medicine since I moved to the area. Before here, I was actually an ICU doctor in Phoenix. I worked at a huge hospital in Mesa, 1,100 bed hospital with 40 ICU beds. Huge hospital. It's even bigger now. It's one of the banner hospitals. So why do I do it? I love it. It's, pulmonary and critical care medicine is very, very challenging. It's very complex. When the heart and the lungs start getting sick, it's funny how the rest of the body starts getting sick. So a lot of my patients that I see with chronic lung conditions have a lot of other organ system problems that I help manage as well. But it can be very complicated, very challenging, but it's also extremely rewarding. And one of the most rewarding things I get from it is the relationship I build that I build with my patients. In fact, just this morning I saw a lady that I've been seeing for probably 7 years who drove all the way from Aztec to see me today. So a lot of the relationships I built with my patients in Durango, a lot of people are going to be coming over here for a variety of reasons. But, I have friendships with some of these folks and just an incredibly long, rewarding, fruitful relationship with a lot of my patients. And I love to watch, unfortunately, with the nature of some of their illnesses, a lot of people don't necessarily get a ton better. But we strive to give them treatments that will preserve their quality of life as best we can. And watching patients respond to therapy, the story I love to tell people, I see a gentleman who's a contractor in the Four Corners area with lifelong asthma. He's had asthma since he was a kid. And before I started seeing him, he needed prednisone therapy, prednisone pill therapy to control his asthma at least once a month. He was 50 pounds overweight because of the prednisone, had diabetes, and I started him on a new immunotherapy for asthma. That was 8 years ago. He has not needed a single tablet of prednisone since I started him on that therapy. So that's just a great example of some of the things that we do for the patients that just have amazing benefit for their disease, their quality of life, their functionality, everything. So, next. So, my practice philosophy isn't unique. Thorough, comprehensive, evidence-based, guideline-based medicine. So the American Thoracic Society, the American College of Chest Physicians, the American College of Physicians, are the guidelines that we follow for all the therapies that we do. And that also includes the diagnostics that we do, and I'll get into some of that in a minute. But everything is very evidence-based, very, double-blind, placebo-controlled, based allopathic medicine. Next. Okay, so this is a short list of some of the things I take care of. Of the things on that list that are probably the most prevalent, COPD and emphysema, asthma, and one of the ones that's not on there that is very common is sleep apnea. The last statistics on COPD and emphysema in the state of Colorado, about 5% of the population in Colorado has COPD, and it still it can be a lethal disease. It's about 104 out of 100,000 causes of death in the state of Colorado just this last year. So it can be a very, very serious condition. Asthma, super common. Nationally, 24% of population state to state have asthma. It can be a very serious condition. It's also a very treatable condition. So those are two of the most common conditions I see. And then there's sleep apnea, which is not on the list, but sleep apnea, the statistics would astound you on the number of people in America that have sleep apnea. The last statistics from the American Thoracic Society, 26% of Americans have sleep apnea. Huge number. And we diagnose and treat that here as well. Some of the other conditions, bronchiectasis, which is a chronic airway infection condition, which can be very life-altering. We can manage that. Interstitial lung disease, scar tissue in the lungs, pulmonary fibrosis. Lung cancer, our job with lung cancer is to diagnose it and stage it with bronchoscopy. And then once we kind of make the diagnosis, then we send them to oncology, which we can do here, obviously. Pleurisy, inflammation and infection around the lung and the pleural space, pneumonia, blood clots in the lungs, pulmonary embolism, we take care of that. Pulmonary fibrosis, already mentioned, and then pulmonary hypertension, high blood pressure in the lungs. Very common at these altitudes. Low oxygen levels cause pulmonary hypertension. It makes the blood vessels in the lungs clamp down. If that goes on for a long time, it can cause the heart to weaken and people can develop heart failure from it. We have lots of treatments for it, and a lot of people, it's just putting them on some oxygen, whether during the day or at night, treating their sleep apnea. And if those don't work, we actually have a variety of pills. It used to be IV medicines. Now we do oral medicines that are very good at treating pulmonary hypertension. I did a lot of basic research in pulmonary hypertension when I was at Vanderbilt. It's kind of my niche with pulmonary medicine. So that's something that we see a lot of. Pulmonary hypertension is a little bit of a multidisciplinary condition where I work hand in hand with cardiology. They will often help me with the diagnostics part of it, and then I do the therapeutic part of it. Okay, next. So what are the testing we do? So as of, let's see, so we're getting our lab tomorrow, right? We're hoping?
We're supposed to be here last week, but it's not, it's coming tomorrow.
Has anybody had pulmonary function tests? I know. Anybody else? Okay. So pulmonary function testing is kind of a pulmonologist EKG, if you will. Cardiologists have to have some very basic, essential things to help do their job. And an EKG is one of the, bread and butter things that cardiologists do. Pulmonary function testing is our bread and butter, okay? And basically when we do pulmonary function testing, it allows us to determine how well you're blowing air out, how well you're pulling air in, how well the oxygen's getting into the lungs and soaking into the blood. They've been around forever, but it is that and a good old chest x-ray are at the real core of what we do. It helps establish the diagnosis. It helps us monitor response to treatments. So spirometry, which is a part of the complete pulmonary function test, are something we will do a ton of. And now that we're going to have a lab here, we can do it here. The methacholine challenge test is a special type of spirometry test that actually helps me diagnose asthma. I see a ton of people who come in with kind of vague symptoms or a lot of times it'll just be a cough that's been lasting for years. And the methacholine challenge test allows us to figure out why they've been coughing. And it turns out that it's very, very diagnostic for asthma. So it's a really nice test to have. And that'll be part of our battery of pulmonary function tests. The 6-minute walk test is kind of like, it's basically a poor man's exercise test. And it is exactly what it sounds like. We actually have people do, it looks like a driving test around cones, and they do laps for 6 minutes. And we measure their heart rate, their blood pressure, their oxygen levels, their shortness of breath scores. We use it both for diagnostics, and we also use it to monitor how well people are responding to therapies. We use it for people with scar tissue in their lungs. We use it for people with COPD, people with pulmonary hypertension that are on medications for it. So really nice test, very simple test, billable, reimbursable. So next. So as far as procedures that I do, I have a large array of procedures that I'm trained to do. Most of them are ICU based. As far as pulmonology procedures, the two that I do, and I'll be doing here, one is called bronchoscopy. I'm sure some of you have had a colonoscopy. Yes? Okay. So think of a miniature colonoscopy scope. That's what a bronchoscopy scope is. It's about that long. It's about as big around as this pen. And it's fiber optic. So it's got a camera and a light on the end of it. People are under mild sedation for it. The scope is then slid through the airways, and I can actually drive the scope around the bronchial tubes, just like a GI doctor drives a scope around somebody's colon. Okay. While I'm in there, I can look at the airways. I can biopsy any types of lesions that are in the airways. I can pull mucus out of the airways. We can do fluid samples out in the edge of the lung. That's called a lavage. And out there, we actually squirt salt water out into the edge of the lung and then suck it back up. So we're getting a sample of what the cells are like lining the outside of the lung. And then I can also do little biopsies of the lung, little pinhead-sized transbronchial biopsies. And all these are for diagnostics, right? We're trying to diagnose. We see people with weird abnormalities on CAT scans, and people can't figure out what they are based off the history and physical. And the scope is the way to figure out what it is. And then the newest kit on the block that's actually been around for a while, I've been doing it for probably 9 or 10 years, is called endobronchial ultrasound. So it's a similar scope. It's a fiber optic scope, about the same size. But this scope has an ultrasound probe on the very tip of the scope. When I go in with the scope, I can actually put the scope against the wall of a bronchial tube and look through the bronchial tube and see what's on the outside of it. So we use that primarily in people that have a diagnosis of cancer, and we're trying to stage the cancer, figure out how extensive it is. Is it in the lymph nodes or not? There are hundreds and hundreds and thousands of lymph nodes in the middle of the chest around the bronchial tubes. And endobronchial ultrasound allows us to biopsy that. In the old days, before endobronchial ultrasound, you had to go see a surgeon and do an operative scope behind the sternum to get the lymph node biopsies. We don't do that anymore because we have endobronchial ultrasound. So it's a very neat tool, and it's very simple, very low risk, and it basically keeps a patient from having to go see a surgeon. So very nice. Next. So like I said earlier, so this is called a plethysmograph, also known as a body box. All right. So basically, when the patient gets in, the door is closed and it's sealed. Okay. We know exactly how much volume of air is inside this chamber. Then the patient, with a clip on their nose, takes big breaths in, and then we remeasure the amount of gas inside the chamber. And then you just make the difference. And that's the volume of air that the person's pulling into their lungs. Right? So that's called basically total lung capacity. We get a ton of information from this body box or plethysmograph. And then, so that's what we call the lung volume part. The other part is the spirometry, which is not in this picture. And basically, that's basically where they sit in a chair, take big deep breaths in, blow out hard, and there we're measuring how well they're blowing air out. So we're measuring how well they pull air in with this box, and then we measure how well they blow air out with the spirometer. Okay? And we use it for everything. I mean, it is, again, it's the It is one of the essential tools of pulmonology. We can help we diagnose COPD and asthma with it. We diagnose pulmonary fibrosis and other diseases that cause the lung volumes to shrink. And then we also use it to see how people monitor how they respond to therapies. So, for instance, I'll sometimes see a patient with COPD, and I'll start them on a new inhaler regimen, and I'll say, let's see you back in 6 weeks after we've had you on the inhaler regimen, and we'll remeasure your lung function and see how much better it is. We also use it for prognosis, although it's very hard to. A lot of my advanced COPD patients will want to know how long I got, doc. And the answer is it varies very much so from person to person. But getting the baseline set of PFTs gives us some kind of ballpark of what their longevity is going to be with their condition. So, next. That's me with my shiny bald head. So the patient process. Referral from primary care. Usually what we like to do before we see them is get a baseline chest x-ray and the pulmonary function testing. So I know kind of what we're dealing with before I go in and see the patient. It's not absolutely essential, but it is nice to have that data before I actually sit down and talk to the patient. And then I take my time with my visits. I'm not one of these docs that walks in with a laptop and starts tapping away and kind of doing this. I don't even bring a computer into the room. I'm pretty old-fashioned when it comes to that stuff. So most patients will tell you I spend a lot of time with them, taking very, very thorough history and physical. And it's greatly appreciated this day and age, as a lot of you have experienced with healthcare these days. And then the plan of care is based off of what I get from them and their history and what they sound like, what their x-rays look like, what the PFTs look like. We come up with a plan of care and treatment and then follow-up. Pretty simple. Okay? Next. Oh, that's it.